Welcome to the October 2023 LACNETS Education event. My name is Lisa Yen. I'm the Director of Programs and Outreach at LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach at LACNETS.
Today's presentation is on symptom management with Dr. David Metz. A special thanks to Ipsen, ITM Pharmaceuticals, Advanced Accelerator Applications, and Crinetics for supporting our LACNETS patient education programs. LACNETS stands for Learn, Advocate, Connect, a neuroendocrine tumor society. Our name also states the mission of our patient advocacy organization. Our team includes our Executive Director, Kavya Velakapudi, and Heather Davis, our Associate Director of Advocacy and Outreach. The board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joyce Mbesi, and NET patient Mary Dunleavy, who has been living and thriving with NET for 18 years. LACNETS is now partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance. For more information, visit lacnets.org/support line. I'm now going to hand it over to Heather to share some important tips about today's programs.
Thank you, Lisa. Our YouTube channel features over 300 videos and podcasts. Use our playlist to find webinars on PRRT, liver-directed therapy, clinical trials, imaging, nutrition, PhioPara, and our annual conferences. Follow LACNETS on social media. We are on Facebook, Twitter, and Instagram with the handle @LACNETS. And be sure to add us to your Safe Sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the experts' personal opinions. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it back to Lisa.
Thanks, Heather. Because I am a NET caregiver, I, like you, try to stay informed and engaged about the latest in NET treatments and also about clinical trials. We understand that clinical trials pave the way for future treatments. This year, we launched our Clinical Trials Guide. It's an educational resource that features some key clinical trials for neuroendocrine cancers. You can find patient-friendly videos and information about individual trials, and we hope this guide will help you better understand various NET clinical trials. I'm excited to introduce today's speaker, Dr. David Metz, a well-known and respected NET expert, or as he calls it, a netologist. Dr. Metz was at Penn Medicine in Philadelphia for 28 years, where he served as the co-director of the Neuroendocrine Tumor Center and the Penn NET Treatment Program. He also served as the chair of the North American Neuroendocrine Tumor Society, or NANETS, and on the Food and Drug Administration Gastrointestinal Drug Advisory Committee, among other significant positions. He was an investigator for many prominent clinical trials and published more than 200 articles. Dr. Metz retired in July 2021 and now lives in Southern California. In 2021, Dr. Metz was also honored with the NANETS Lifetime Achievement Award that honors an individual who has provided outstanding contributions to neuroendocrine disease management through research, clinical practice, or educational initiatives, as well as exceptional leadership in NANETS and dedication to its mission. One fun fact about Dr. Metz is that he was previously a game ranger in South Africa, and he has seen many zebras in the wild. Welcome, Dr. Metz.
Hello, my name is David Metz, and I'll be joining you today to talk about symptom management in neuroendocrine tumors. So, to begin with, I'd like you to focus on this upside-down triangle on the right side of this slide. And this is different from other malignancies. I attribute this to my good friend Rod Pommier, who suggested this way to demonstrate the way neuroendocrine tumors grow. At the bottom of the triangle, the point of the triangle, you see the primary. And that's a small tumor usually. Afterwards, the primary spreads to develop lymph nodes. And in neuroendocrine tumors, the bulk of the lymph nodes can be excessive and larger than the primary tumor. And then from the primary tumor to the lymph nodes, the tumor then spreads further to metastases, which are usually first in the liver and then can be elsewhere, including the bone. And the bulk of those tumors tends to be even greater still. So you think of neuroendocrine tumors as being a sort of upside down tumor with small primaries, large conglomerate lymph nodes associated with that primary, and then significant bulk in the metastases. And as you can see, if that is the way these tumors would present, then you would expect that it would take a long time for primary tumors to be detected. And in fact, more often than not, patients are often identified by the time they've developed metastases. So if we move over to the left side of the slide, I show here the three patterns of presentation. First of all, asymptomatic. Second of all, with tumor symptoms. And third, the hormonal syndromes that these tumors can produce. So asymptomatic tumors, which can be found completely incidentally, whether they are still localized and resectable or whether they are widespread, may present with no typical symptoms, and the patient might end up getting an imaging study for some other related reason. The second way patients present is with tumors, and the tumors themselves are causing the symptoms. The growth of the tumors are presenting the symptoms, and as I've just alluded to, that would be quite late in the presentation, and the symptoms are usually from the metastases or from the lymph nodes rather than from the primary itself. And the third way that tumors present is from those that are functional. Roughly 30% of all neuroendocrine tumors are functional. And by functional, I mean they produce products that give hormonal symptoms. Those are the hormonal syndromes associated with neuroendocrine tumors. And at this type of presentation, patients could present early enough that you could find them, resect them, and actually achieve an easy cure. But this, of course, requires putting two and two together. It requires an astute physician. So these are some of the dilemmas that we approach with neuroendocrine tumors. Functional neuroendocrine tumors are relatively rare, and doctors are usually trained that if you hear hoofbeats, it's usually from horses, not zebras. In other words, don't think of unusual diseases, think rather of what's going to be common. Other more common diseases have very similar sort of presentations. If you've got a hammer, everything looks like a nail. If you see common symptoms, it's always going to look like what you normally see. And these symptoms are very, very variable. So the presentations occur with different conglomeration of symptoms and syndromes depending on what it is. And you're really looking for a needle in a haystack. So as I suggested, diagnosis early on of functional neuroendocrine tumors requires an astute physician who could put two and two together. And again, why this is so important is that early diagnosis has prognostic implications because surgery is the only curative modality for neuroendocrine tumors. Remember, the mean time to diagnosis for neuroendocrine tumors is 5 to 7 years. So, what are the functional neuroendocrine tumors? On this slide, I've mentioned primarily that it is an inappropriate release of normal hormonal products. All of these products that the tumors produce are normally found in the body and have various jobs to do. It is only when you have abnormal amounts of the normal products in the bloodstream causing distant symptoms that you have functionality and an unexpected syndrome. So to have a functional syndrome, you have to have both the symptoms that the hormones would produce, as well as a biochemical confirmation, a blood test that shows that those products are elevated. It is not determined purely by immunohistochemical staining, and taking out a tumor and staining for any products does not make the diagnosis. In fact, many tumors stain positive despite the fact that the products aren't necessarily released or are released but don't reach enough of a threshold to cause symptoms. The bottom part of the slide reveals the far more common functional tumors, which are all very rare. The carcinoid syndrome is in a category itself above for two reasons. One is that it is far and away the most common syndrome, twice as common as the next. And secondly, because it classically occurs in the small bowel, although it can occur in the lung, it can occur in the pancreas, it can occur in the testes. So on the diagram on your right there, it's the road that's running in the valley of that lake that's draining into the small bowel. The next category, insulinoma, Zollinger-Ellison syndrome, glucagonoma, and vipoma, are separated because those are the classic and more common pancreatic neuroendocrine tumors. The pancreatic neuroendocrine tumors, generally speaking, are half or less as common as the carcinoid syndrome. Insulinoma and Zollinger-Ellison syndrome being the two most common, those are about half as common as carcinoid syndrome. Glucagonoma syndrome is very rare, and vipoma syndrome is very rare, but these do occur and are seen, and I think we should talk about them today. Those below the line, the ACTH-oma that causes Cushing's syndrome, the GRF-oma that causes acromegaly, the somatostatinoma tumor that causes hyperglycemia, steatorrhea, gallstones, and other rarer tumors like calcium-producing or erythropoietin-producing tumors are exceedingly rare, and we're not going to necessarily touch on those symptoms today. Finally, the bottom one, the PPomas, is actually the most common tumor, neuroendocrine tumor of the pancreas, the PPoma, pancreatic polypeptide secreting tumor. And although the PPoma produces a product called PP, it does not cause symptoms, so it's actually a non-functional tumor. Okay, so we're going to start off with the carcinoid syndrome. This slide lists the more common symptoms of the carcinoid syndrome. Far and away, the most important symptoms are flushing and diarrhea. The other four relatively common ones are heart valve lesions and cramping. I must modify that, in fact, because heart valve lesions, although they're listed as occurring in about half the patients, are not in current practice that common because patients are coming to diagnosis much more commonly, and this is usually a late finding with fibrosis in the heart that can cause significant valve disease. Despite that, you do see patients on occasion walking in de novo with right-sided heart failure as their first real presentation for the carcinoid syndrome. But flushing and diarrhea make up most of the original presentation. The cramping can be from the diarrhea, can also be from fibrotic responses in the small bowel, in the lymph nodes, in the mesentery that cause various degrees of obstruction. And so pain in the abdomen is also a relatively common symptom with carcinoid syndrome. But if you think about flushing, diarrhea, maybe heart disease and cramping, that would account for many patients presenting to doctors, and this really is a sort of needle in a haystack diagnosis. There are other important clues listed in blue here that are less frequent. Telangiectasias, or little vascular malformations, classically on the face, do develop with chronic exposure from the carcinoid syndrome. Peripheral edema or swelling of the ankles, especially in patients with right heart failure. Wheezing can occur from spasm in the bronchi and bronchospasm, much like asthmatic wheezing. Going blue or cyanosis and blueness in the fingers is seen on occasion. And chronic patients with carcinoid syndrome get arthritis. Pellagra, which is a consequence of niacin deficiency, is a vitamin deficiency. It occurs in this syndrome in patients who've been long-standing because the tumor sucks up the niacin to make it serotonin, which is one of the major products of carcinoid syndrome. And so pellagra may be a sort of presenting symptom in long-standing patients. But with this whole conglomeration of unusual symptoms, you can see how patients can have difficulty coming to a firm diagnosis. This is a diagram that came from the NET Alliance monograph we put out many, many years ago to try and raise awareness for the carcinoid syndrome. And it shows some of the more common differential diagnoses that are confused with carcinoid syndrome, so that many gastroenterologists will label patients necessarily as Crohn's disease or ulcerative colitis. Those are the two inflammatory bowel diseases, or even more commonly, irritable bowel syndrome, which is extremely common and probably the major cause for diarrhea that people see, both gastroenterologists and regular general docs. And so you can see that the diarrhea associated with carcinoid syndrome can be mistaken with these other causes of diarrhea, although the carcinoid syndrome is classically a watery diarrhea that occurs at night. It does not stop at night, and it does not stop if the patient fasts. And that's because it is a secretory diarrhea. The products that the tumor produces makes for secretion of fluid into the bowel that causes diarrhea. Now, Crohn's and ulcerative colitis can cause secretory diarrhea, usually not as severe. It is very uncommon in irritable bowel syndrome. Rectal bleeding is another distinguishing feature. It's unusually the carcinoid syndrome, although it can occur, usually if the tumor is eroded into the small bowel. That is far more common to have diarrhea with blood associated with inflammatory bowel disease, and it's very uncommon in irritable bowel syndrome. In fact, it would be a diagnosis to avoid if you see irritable bowel syndrome. As far as the constipation association is concerned, classically irritable bowel syndrome can present as irritable bowel syndrome diarrhea predominant, irritable bowel syndrome constipation predominant, or irritable bowel syndrome alternative, both diarrhea and constipation. And if there is constipation, it's really not a classic feature for carcinoid syndrome, except very late in the disease by the time you get bowel obstruction from tumor. It is infrequent to see constipation in ulcerative colitis. It is a finding in patients with Crohn's disease. And I've already mentioned abdominal pain. Intermittent, crampy, or colicky abdominal pain does occur from the volume associated with carcinoid syndrome, or later on in the disease with obstruction. Crohn's disease, it's a major feature from stricturing, not so common in ulcerative colitis, but in irritable bowel syndrome, pain is ubiquitous and is required for the diagnosis. What about getting relief of the pain after a bowel action? And that's another distinguishing feature. Irritable bowel syndrome classically goes away. The pain goes away after a BM. In UC, it usually does. Crohn's disease is kind of variable and may not be helpful. And in carcinoid syndrome, it's a variable sort of finding. So one needs to be very careful about how you look at all the features of the presentation before jumping to conclusions with diarrhea. And these are the features that are more in favor of carcinoid syndrome than irritable bowel syndrome, many of which we've already discussed. Older age, IBS is usually a young person's disease. Men, both men and women do get carcinoid syndrome, roughly equal. Men maybe a little bit more, but IBS is much more common in women. Persistent symptoms that are of increasing severity and don't go away. If you get your IBS as bad as it can be, and it can be quite disabling, it usually doesn't get worse and worse and worse and worse with time. So if your patient is repeatedly coming back, you need to think about that. I've already alluded to the nocturnal diarrhea component, which is very, very unusual in IBS. A secretory diarrhea, in other words, a diarrhea that occurs because fluid is secreted into the bowel, is typically associated with carcinoid syndrome and other neuroendocrine tumors. There is a way to test for that with stool studies looking for an osmolar gap, as opposed to an osmotic diarrhea in which the fluid is sucked into the bowel because of osmotically active substances, such as in lactose intolerance. It's a different feature of the diarrhea, and it only occurs in the presence of those components. IBS isn't really either of those. It's more even a frequency of diarrhea as opposed to an absolute increase in volume of diarrhea. The normal stool volume is 250 cc's a day, and the normal number of bowel actions a day is every third day to 3 a day, so that it's quite variable. If there are associated systemic complaints such as weight loss, flushing, wheezing, pellagra, dehydration, obstructive symptoms, the sort of symptoms we spoke about earlier, one needs to think of the carcinoid syndrome. How about diagnosing the carcinoid syndrome? As I've alluded to, a syndrome is a syndrome. It means a collection of symptoms. But to diagnose it, you can have the perfect collection of symptoms. You need to show that the hormone is abnormal or the product is abnormal. The standard tests for carcinoid syndrome is a 24-hour urine test for 5-HIAA, and that is the most validated study and the one most people accept. Unfortunately, lugging the jug, as patients know, is a pain to carry around a jug for 24 hours. And so there are other approaches. Some people look at serum serotonin as being predictive. Unfortunately, many people think it is too variable and is not really helpful for a diagnosis. On the other hand, plasma 5-HA is gaining traction, and people are now starting to look at the possibility of measuring a plasma level of 5-HIAA, and this has been validated in a small number of studies. Also, chromogranin A is very important to mention. It is not specific. And to diagnose a hormonal syndrome, you need to be specific. You need to prove that that's the product causing the symptoms. Chromogranin A itself, although it's a product of neuroendocrine tumor cells, doesn't cause any symptoms, and in fact can go up with any neuroendocrine tumor. So it's not diagnostic of a syndrome. In addition, remember, you can get false positive 5-HIAA levels with certain foodstuffs, walnuts, avocado pears, bananas, butters, kiwi pears, etc. And those products should be avoided for the tests, although to see a really high elevation with those products is not classic. In addition, other products that it can interfere with 5-HIAA are some medications, namely Tylenol and guanefacin, which is used for cough and wheezing. I've already spoken about chromogranin A not being very specific. Any other net can produce it. Proton pump inhibitors, which are anti-secretory drugs used for reflux disease, are used in many, many patients. And they cause an increase in ECL cells that release products including chromogranin A, and that can give you a false positive result. In addition, and very important in our patient populations, irritable bowel syndrome, IBD, can give you false positive chromogranin A, as can chronic liver disease and cirrhosis or chronic kidney disease. So with that, That is a brief rush through carcinoid syndrome. We'll now focus on insulinoma, gastrinoma, and glucagonoma before we get onto some treatments. Insulinoma. Insulinoma is called a beta cell tumor. In other words, it's a tumor of beta cells, often in the islets of the pancreas, that release insulin that cause excess insulin and low glucose, and that is a result of the insulinoma syndrome. It is the most common functional neuroendocrine tumor, and it is almost always in the pancreas. They are generally benign lesions in contrast to the other neuroendocrine tumors. However, about 15% of these are malignant, just like the other neuroendocrine tumors. So if you find an insulinoma, it's always best to remove it. Unlike many of the other neuroendocrine tumors I've already mentioned, they're almost always in the pancreas, and they are almost always solitary if they are in sporadic patients. If they occur in sporadic patients, they should be removed because you can cure the syndrome that way if you can identify it. Now, multiple endocrine neoplasia type 1 is a hereditary syndrome we'll talk about very briefly. The reason I'm bringing that up is that patients with MEN1 syndrome often get insulinomas up to about 60% of the time. And those that do get insulinomas often have other lesions, PPomas, Zollinger-Ellison syndrome tumors. And so in those cases, it's kind of difficult to find which is the MEN1 insulinoma that's causing the symptoms. And there may be more than one lesion. So the management of those patients differs. The classic clinical feature of insulinoma is what is called Whipple's triad. And that is the following three things: hypoglycemic symptoms, symptoms from low sugar, with a proven low glucose, a low sugar in the blood, that goes away if patients eat. And patients learn as these symptoms develop with time and the syndrome gets established that if they rush out and eat, they will resolve some of those symptoms. So surprisingly, many patients are overweight. The symptoms typically will occur during periods of relative substrate deficiency. What do I mean by that? It's when the organs that require glucose for functioning are active that glucose gets sucked down and insulin is too high to allow that glucose to recover. So in periods of exercise or periods of fasting is when insulinoma patients start finding that they're feeling uncomfortable. And as I've already alluded, unexpectedly, despite the fact that it's an excess of insulin and insulin drives glucose uptake, these patients are often overweight because they learn to eat to control their symptoms. So let's go through those three symptom groups again and divide them here for you so that you can see how difficult it is to often diagnose this syndrome and why patients with insulinomas can present to neurologists, psychologists, dermatologists, endocrinologists, gastroenterologists, and it takes a while to diagnose it. Neuroglycopenia alludes to the neurological consequences of a low glucose count, and the brain and central nervous system requires glucose for energy. It cannot derive its energy out of fat. As a consequence, patients are labeled as having amnesia or coma, confusion, visual changes, convulsions, and altered consciousness. When your glucose level is low, your body senses this and tries to drive up the glucose with a sympathetic neurological response. It is what people describe as being insulin shock. The patients with diabetes who might be overdosing on insulin or taking more than they take an associated substrate to deal with that insulin. So sympathetic overdrive presents as the fright and flight reaction: weakness, sweating, tremors, palpitations, hyperphagia. That's excessive eating. And third group of symptoms, as I've mentioned, is obesity. Now, just like any other neuroendocrine syndrome, this is an inappropriate amount of a normal substance, insulin. So appropriate hyperinsulinism occurs in a whole group of other diseases, including conditions like reactive hypoglycemia. We're not talking about those. The inappropriate hyperinsulinism syndromes are listed on this slide on the left-hand side. Classically, the insulinoma syndrome or nocidioblastosis, which occurs in the pancreas. I'll get back to that in a second. Exogenous insulin that is delivered pharmacologically, that can mimic the insulinoma syndrome. Antibody syndromes in which you have antibodies to the insulin receptors so that the excess of insulin doesn't do its job properly, and you can get hypoglycemic from that. And then other drugs used for diabetes in which you will get a high insulin as a response, but it isn't helping, and the patients develop inappropriate hyperinsulinemia. Now, I alluded too quickly to nocidioblastosis. Nocidioblastosis is a very rare condition in which you get multiple small little insulinomas all over the pancreas. It's associated with multiple endocrine neoplasia type 1. It is seen in patients who've had gastric bypass surgery, who are hyperinsulinistic, and you cut that out, but given in the bypass, they don't eat enough and they get hypoglycemic. How do you distinguish all of these? The pancreatic causes, of which insulinoma replaces nocidioblastosis the vast majority of the time, has a low glucose, a high fasting insulin, a high or normal C-peptide level. C-peptide is an endogenous substance that is associated with the development of or formation of insulin. Proinsulin, another endogenous substance that is part of the formation of insulin. Insulin receptor antibodies are usually not there because it's not an antibody syndrome, and looking for abnormal drugs are usually not there. So the first four components will help you prove insulinoma syndrome. If it's somebody who's taking exogenous insulin, either surreptitiously or overdosing without knowing it because of diabetes, they don't have C-peptide because the insulin that is administered is not with C-peptide and is not with proinsulin. It's only the end organ insulin that's injected. Again, antibody syndromes, they will have a positive receptor antibody, and if it's a drug like a sulfonylurea, those will be detectable in the blood. So presenting with just the inappropriate hyperinsulinism, the syndrome, is not diagnostic until you've done these additional tests. Now let's move on to Zollinger-Ellison syndrome. I alluded to the islets of the pancreas having alpha cells, beta cells, gamma cells, and delta cells. The first was the beta cell insulinoma. And so when Zollinger-Ellison syndrome came along a few years later, they realized it was also a pancreatic neuroendocrine tumor, but it wasn't from the beta cell, so it was called a non-beta islet cell tumor, as people were learning which those cells were in those days. This is a cell that secretes gastrin. Gastrin is a hormone that drives acid secretion in the stomach. So as a consequence, patients will get gastric acid hypersecretion, excessive acid production because of an inappropriate elevation of the normal gastrin. We'll get to the pathophysiology soon. That excess of acid produces the triad of Zollinger-Ellison syndrome, which is the beta islet cell tumor, hypersecretion, and fulminant peptic ulcer disease. Most of these are malignant. In fact, we tend to think almost all of them are malignant. Again, with MEN1 syndrome, it comes in two flavors. About a third of the cases are from MEN1 syndrome, but most of the Zollinger-Ellison syndrome patients are sporadic. In other words, they don't have MEN1 associated. Interestingly, and as in opposition to the insulinoma syndrome, more gastrinomas are actually found in the wall of the duodenum than in the actual head of the pancreas itself, the so-called gastrinoma triangle of Stabile, which is put onto this diagram at the junction of the cystic and common bile duct, the junction of the second and third portion of the duodenum, and the junction of the head and the neck of the pancreas. In that triangle, you will find almost all gastrinomas, and surgeons who are looking for gastrinoma tumors can go and search in that area, although as occurs on occasion, this isn't a hard and fast rule. So what about the pathophysiology of Zollinger-Ellison syndrome? Everything in red is a normal pathway. The ECL cell, which you see in the middle of that slide, secretes histamine, and that histamine acts on the parietal cells, the acid-producing cells in the stomach, to make acid through an active hydrogen potassium ATPase enzyme. By doing that, it lowers the pH in the lumen of the stomach, and that lower pH in the lumen of the stomach normally switches on D cells in the lining of the stomach to make somatostatin, a substance I'm sure you've all heard of, a paracrine substance. It's a substance that works locally to inhibit the ECL cells from secreting more insulin and stopping the forward drive to acid. So normally when you eat, you raise the pH of your stomach because your food is not acidic. That stimulates histamine. Histamine causes acid. That acid lowers the pH, and that then switches off the G cells and the ECL cells in the stomach, and you don't remain hypersecretory. In a neuroendocrine tumor in the pancreas or duodenum that secretes gastrin, a gastrinoma tumor, you will release the gastrin. That's the blue diagram there on the right. That causes the hormone gastrin to get into the blood and get delivered to the stomach. And in the stomach, it will bind to the parietal cells directly, top left-hand corner, and also stimulate the ECL cell to make histamine. That's the middle of the parietal cell. The ACTH comes from vagus nerve, which is not part of this particular flow loop. And the cyclic AMP and calcium that are driven by those two products causes the hydrogen potassium ATPase to make a whole lot of acid, lower the pH, And although the somatostatin gets switched on in the stomach, it's a paracrine substance that doesn't get in the bloodstream. It has a very short half-life. And so the gastronoma cells are not switched off, and you get inappropriate hypergastronemia, hypersecretion, and ulcer disease. Classically, duodenal ulcers. Less than 1 in 1,000 duodenal ulcers, however, are from ZE. And most of the duodenal ulcers that we see are from H. pylori, which is an infection in the stomach, or non-steroidal anti-inflammatory drugs, which many people use for arthritic complaints or aspirin for cardiovascular issues. However, if you see a patient with duodenal ulcer disease, when do you think of ZE? First of all, if it's severe, multiple ulcers in unusual positions, or ulcers with complications. Complications would be perforation or bleeding or obstruction. And up to 7% of the time, patients with complications actually have ZE, which is much, much, much higher than the frequency of complications in idiopathic peptic ulcer disease. In addition, gastroesophageal reflux disease from that excess amount of acid getting up into the esophagus is seen in about 2/3 of patients with Zollinger-Ellison syndrome. Although GERD is very, very common, it's only about 15 to 25% of the population that gets GERD. So again, lots of GERD, lots of ulcers in unusual positions. I already alluded to that gastric ulcers not being typical for ZE, and that's because gastric ulcers is more on the cytoprotective side than the excessive hypersecretion side, and is not a classic finding. Not everybody gets abdominal pain with Zollinger-Ellison syndrome despite having ulcers, and that's because the duodenum gets so used to seeing all this acid that the pancreas starts churning out bicarbonates to buffer that acid, and actually by buffering all that excess acid, patients get diarrhea because of lots of acid and lots of bicarb, but they may not get as much pain. And the diarrhea, which is classically seen in patients with ZE and not in typical peptic ulcer disease, can actually occur in isolation. Once again, this is a secretory diarrhea, as I alluded to earlier with the carcinoid syndrome, and it can be looked for looking for osmolar gap with stool studies. One of the pathognomonic features of Zollinger-Ellison syndrome is that it responds to nasogastric aspiration. So all of the symptoms of ZE are from gastrin, and all of the effects of gastrin are on the stomach to cause chronic gastric acid hypersecretion. And if you put a nasogastric tube down and suck out all that fluid, other than causing dehydration with time, you will take away the diarrhea, you'll take away the pain, you'll take away the heartburn, and you'll take away the symptoms. I've already mentioned the most common causes of peptic ulcer disease are H. pylori infection and non-steroidal findings. So if you are 100% sure your patient is not taking non-steroidals, and you're absolutely sure that they don't have H. pylori, which requires breath testing or biopsy, you will be indicated you should think about Zollinger-Ellison syndrome in that setting. So diagnosing Zollinger-Ellison syndrome, again, as I mentioned with the insulinoma, the issue here is inappropriately elevation. So elevated gastrin level alone is not helpful. And there's lots of variability in how labs measure it. And even if the numbers are very high, an elevated gastric level could be appropriate. And the perfect example of that is a patient who's taking proton pump inhibitors at a very high dose, or somebody who has pernicious anemia and atrophy of the stomach and cannot make acid. The body tries to make acid and you get high gastrin, but in those cases, it's appropriate because the gastric pH is not low. In other words, they're not making acid. So you need to have the acid, elevated gastrin level and proven acid hypersecretion, which is unfortunately very difficult in clinical practice because gastric analysis, which we used to do in the old days, is invasive and not commonly done. An isolated measure of the gastric pH is potentially not as useful, although many patients could have it done, and gastroenterologists can suck up juice at the time of an endoscopy. But just having acid hypersecretion without a high gastrin doesn't make this diagnosis. And most importantly is that removing proton pump inhibitors can be a very dangerous enterprise and can result in rebound hypersecretion of acid and sickness. So I always recommend that if you want to prove ZE, you need to be sure it's being done in a controlled setting. But you do need to have hypergastronemia that is inappropriate. There used to be old tests, the secretion test, which is still done in lots of patients. Secretion testing is only positive in about 87% of cases, and there are false positives, especially in patients who have achlorhydria. And the calcium infusion test is a very old test, and that can cause seizures, so people should not be doing that one. So what are the causes, again, of appropriate and inappropriate hypergastremia? We've listed some of the appropriate ones already and discussed them. That's not part of today's discussion, but there are other causes of inappropriate hypergastremia. And the most important one, of course, is Zollinger-Ellison syndrome, either sporadic or multiple endocrine neoplasia type 1. The two other conditions I want to mention are the retained antrum syndrome, which is a very, very uncommon syndrome. It is really only seen in patients who've had previous peptic ulcer surgery in which part of the antrum was left behind. And depending on the way the stomach is hooked up again, you can get an inappropriate hypergastremia. It's an extremely uncommon disease, but if you've had peptic ulcer surgery before, that's something need to be excluded. An antral predominant H. pylori infection, a condition that used to be called G cell hyperplasia, excessive G cells in the wall of the stomach secreting gastrin that drives acid secretion, that can lead to hypersecretion and peptic ulcer disease. And being that HP is so common, it is something that needs to be considered. So everybody with ZE really should have a biopsy or a breath test to exclude this condition, although in these patients, the level of hypersecretion is much, much lower. And the other causes are easy to exclude. A last slide on multiple endocrine neoplasia type 1. I did mention this. As I suggested, ZE is often with multiple tumors in the duodenum. This on the left is a picture of a patient with MEN1 who has multiple gastrinomas, and you can see how difficult it would be to treat that other than maybe taking out the whole duodenum and doing a Whipple operation, which is generally not advised too early on in these patients because it can cause significant morbidity. On the other hand, sporadic Zollinger-Ellison syndrome on the right-hand side can be a tiny little tumor, and you see here transillumination of a duodenum in the operating room. That's a 3 or 4 millimeter tumor that the surgeon felt, and the gastroenterologist shone a light through the duodenum so that they could remove that and cure that patient. So early on, if you find ZE, especially in sporadic patients, surgery is often the way to go. Now let's quickly run through a couple more syndromes. The glucogonoma syndrome. It is classified by the 4 Ds: dermatitis, diabetes, DVTs, and depression. Associated other symptoms: anemia, hyperaminoacidemia, low amino acid levels in the blood, weight loss, and classically a glossitis, a red, thin, a painful tongue. In these cases, again, your glucagon level is inappropriately elevated. It often presents to dermatologists and presents late in the course of the disease with a very large primary tumor, and I will show you some pictures of that in the next slide. Cirrhosis can confound this diagnosis, so you always need to be sure because you can get a high glucagon level and a rash, surprisingly, with cirrhosis. And some people feel the rash when it occurs may respond to zinc or amino acids, but classically the treatment for these patients is somatostatin analogs, as it is for all other neuroendocrine tumors. And I hope I'm not spoiling anybody's meal by showing you these slides of migratory necrolytic erythema, which is the migratory rash seen in glucogonoma syndrome patients. It's quite classic. And an experienced dermatologist looks at it and knows it spreads out, hyperpigments, develops blood ulcers, and they pop. But many patients misdiagnosed by people who are not aware of this rash that occurs usually in areas of the body where the skin gets stretched, like in the armpits, around the mouth, on the buttocks, etc. The vipoma is the last functional syndrome I'm going to talk about today. This is a profound secretory diarrhea. It makes carcinoid syndrome and Zollinger-Ellison syndrome look like cadets. These patients present with such severe, overwhelming, dehydrating diarrhea and electrolyte abnormalities that patients call it pancreatic cholera. It's like cholera, but from a pancreatic source. The other term, watery diarrhea, hypokalemia, achlorhydria, WDHA syndrome, is because you get lots of diarrhea with low potassium and absence of gastric acid production for whatever reason related to the VIP action on the stomach. Usually antidiarrheals, Imodium, Lamodal, etc., are absolutely ineffective in these patients. They usually present to gastroenterologists often late in the course with a very large primary, unlike ZE and insulinoma. And the diagnosis requires an elevated VIP level. This can be confounded by old age. So the actual level is often difficult, but it has to be elevated, of course. And the diarrhea, as I've alluded to, is a secretory diarrhea, unrelated to meals, continues at night, no osmolar gap, just like the other ones we mentioned. Okay, so how now then do we treat these diseases? The somatostatin analogs, as I'm sure many people know, the hallmark therapies for all the functional neuroendocrine tumors, in that they work in two ways, both for tumor control as well as for symptom control. And since we're talking today about symptoms, they are the way to go. This is a diagram that I'm sure many people have seen previously of a neuroendocrine cell on the left with its SST, somatostatin receptors. Looks like a sort of tuber over there, the 7 transmembrane domain receptors to which the ligands bind, activating second messenger systems that result in the products being produced. On the top is the human somatostatin, which is a 14 amino acid peptide, and the 4 business end molecules in orange, phi, trip, lis, and threonine, are all going to bind in a specific pocket to that SST receptor and cause a release of hormone. Unfortunately, human somatostatin is paracrine, as we've already mentioned, and if you put it in the bloodstream, it has a half-life of about 2 minutes or less, and so it doesn't really do anything in terms of being used pharmacologically. And as a consequence, the synthetic somatostatin analogs, octreotide and lanreotide, and you can see they have the same business ends, that they have a much longer half-life in the blood, and that's why they can be used therapeutically. And both of these, of course, as you know, are now available also in depot form so that one can get prolonged action as needed. So the first and early studies were done back in the late 90s, and here's one of the early studies looking at the long-acting depot octreotide. Same sort of thing would be seen with lanreotide, and you can see that there's a dose-response curve in as much that using the long-acting depot at 10 milligrams in purple, 20 milligrams in blue, or 30 milligrams in yellow, as time on study, you got a much better level in the blood. Now, many of us who've been treating neuroendocrine tumors with somatostatin analogs use the higher doses because we're treating for tumor control, but there is a dose response if you want to use these drugs for symptom control specifically. So most endocrinologists or gastroenterologists may up-titrate the dose, whereas many oncologists may start at the higher dose and even down-titrate as necessary. But the bottom line is somatostatin inhibition or stimulation with octreotide or lanreotide will control the hormonal syndromes. And here is a very busy slide, hard to read. Don't bother really looking at all the details. What I just want to show you is that the studies are listed on the left. They go back to the 80s and carried on into the 20s, 2000s and beyond for various diseases, carcinoid, pancreatic tumors, insulinoma, glucagonoma, vipoma, and many other functional neuroendocrine tumors with some small, some larger amounts of patients, varying doses of the drug, that almost ubiquitously was a good response with symptoms and also an associated biochemical response, in other words, damping down the release of the product and thereby controlling the symptoms. So that somatostatin analogs are really the drugs of choice for syndrome management. And as I'm sure people know, octreotide and lanreotide are both approved for various conditions. They aren't approved for all of the conditions because those are so rare and people haven't done the studies, but I think they are effective. And in gastronoma and insulinoma, we have some specific considerations that I will get onto. I've already alluded to the fact that somatostatin analogs, and in my opinion, you should use a full dose for this reason. They also have efficacy in controlling tumor growth as primary treatment. So the medical management of functional neuroendocrine syndromes are listed over here. We've already spoken about the somatostatin analogs. As you can see, for carcinoid syndrome, they're approved. For insulinoma, they're approved. For vipoma, they're approved. They're used for glucagonoma. They're also used for gastronoma, especially metastatic disease. But in addition, there are some other considerations. Insulinoma, as I've already alluded to, is usually a small tumor. It's usually solitary in sporadic patients, and surgery may be effective. Sometimes somatostatin analogs don't work as well in that situation. And sometimes, in fact, functional studies like dotatate scans aren't positive in small insulinomas. So that becomes a concern, and we'll touch on everolimus later on. In the gastronomas, the first line of business is to stop the end organ effect of gastrin, and proton pump inhibitors do that very, very well at high doses. And so you may not need somatostatin analogs for symptom control. If there's tumor excess and metastasis, you need to consider treating the tumor as well. And most importantly, in the vipoma syndrome, where patients can get terribly dehydrated, it's important to make sure that that is prevented and that potassium is replaced, because potassium can lead to cardiac arrhythmias. So to move back up then to the alternatives for carcinoid syndrome, telotrestat ethyl, which was previously called telotrestat etoprate, is a tryptophan hydroxylase inhibitor and is approved for patients with stable tumor in whom the syndrome is inappropriately controlled. And the pathway by which tryptophan gets converted to serotonin, which causes at least the diarrhea predominantly, but possibly also other symptoms, complexes, flushing being most important, not as well documented. The pathway is by converting tryptophan to 5-hydroxytryptamine, and that is done with an enzyme, tryptophan hydroxylase. So telotrestat etoprate or telotrestat ethyl was formulated to be administered to patients to block that conversion and therefore prevent niacin deficiency, for example, as well as the other potential concerns, especially the uncontrollable diarrhea and carcinoid syndrome in patients who were inappropriately controlled on a somatostatin analog alone. And here are the data from one of the many trials done with telotrestat etoprate, comparing placebo in black to the blue at 250 milligrams and the green at 500 milligrams, in which you can see over 12 weeks of study, the change in bowel actions being statistically significantly reduced, and patients find that this was a very helpful approach to their management. ZE, I alluded to, is a little bit difficult. Remember, symptoms are not sufficient to control this disease, and patients may tell you they're feeling okay because they've got a lot of buffered acid with bicarbonate, but on the other hand, they can suddenly get into trouble, and missing 1 or 2 doses of PPI can be really dangerous and result in life-threatening bleeding. So I always feel patients should be on twice daily PPIs. If you don't want to do that, you really should measure the acid production, a control BAO, basal acid output. It's a hassle to do, and people aren't doing that frequently. If it is done, there are well-defined endpoints to show the level of control that is required to be safe. MEN1 patients do need higher doses for some reason, and I would recommend anybody with Zollinger-Ellison syndrome have a medic alert bracelet that says, PPI-dependent Zollinger-Ellison syndrome, I can't miss my PPIs, in case you end up in a place where you vomit and lose and don't absorb drugs, you have a response to something and become incapacitated and on a ventilator, and unfortunately people drop the drug. And we know that oral PPIs control symptoms in everybody, and here's one of the studies from the late 90s or early 90s, looking at lansoprazole, one of the PPIs at varying doses, that you can control everybody's acid secretion, as you see on the left-hand side, and on the right-hand side, within 40 hours of holding off drug, everybody will recover. So you need to not miss doses. Now, I also mentioned that insulinomas are sometimes difficult to control, that medical management is sometimes suboptimal, and somatostatin analogs on some occasions can worsen sugars, and that the medical management with diazoxide and other drugs is complicated, so that surgical resection is really favored. They are often solitary and benign and identifiable, and here is the role for an endoscopic ultrasound, because we know that almost all the insulinomas are in the pancreas, and sometimes SSR receptor studies like dotatate scans can be negative. Of course, in MEN1 patients who may have multiple tumors, it may not be as effective to operate necessarily. I also alluded briefly to everolimus, and this is an agent that is approved for tumor control in neuroendocrine tumors. Everolimus has the side effect of raising blood sugar, and this is from an old study back in early 2000s in which 4 patients who required all sort of problems because of glucose control, that when they were put onto everolimus, for some reason, the glucose control was improved. So if patients with metastatic insulinoma are having problems with their sugar control on SSAs, everolimus is potentially a drug that can be used for 2 indications. I want to just get back to this story about refractory diarrhea. Patients with refractory diarrhea who have a neuroendocrine tumor may have many causes for refractory diarrhea. And it's not always under treatment of the Metz syndrome, which is caused by the excess hormone production. In that case, you do need more SSA, or if it's carcinoid syndrome, you want to add a telotrestat. However, there are many other causes, and in fact, giving too much SSA, you will end up with steatorrhea, the second condition on the left here. That is a fat malabsorption, and can also be caused by somatostatinoma, for example. But pancreatic insufficiency, either because it's been operated on or because you had somatostatin analogs on board at high doses, you can have ineffective pancreatic enzyme production, and that can cause diarrhea, but it's a different kind of diarrhea. In addition, many patients with neuroendocrine tumors, especially carcinoid syndrome patients who've had their terminal ileums resected, or patients that have had the gallbladders resected, remember SSAs are associated with gallstones, You can get a bile salts diarrhea. And what happens here is that bile salts, which are normally absorbed in the terminal ileum and recycled back to the liver to be reused with the next meal, leak out, get into the colon, irritate the colon, and cause a diarrhea from colitis. And in those patients, cholestyramine or other drugs that can bind up the bile acid may be a useful therapy. Bacterial overgrowth is another cause of diarrhea in patients with NET syndrome or other conditions. Anybody who has a short bowel, who has dysmotility of the bowel, either from an SSA or because of adhesions or because of previous surgery, those patients could potentially get bacterial overgrowth causing diarrhea, and the treatment there is antibiotics. I personally like rifaximin, though, because it's not absorbed, although it's difficult to get it approved for that particular indication. Pellagra, from carcinoid syndrome or not, with niacin deficiency, can cause diarrhea. Diabetic diarrhea is classically well described in patients who have nerve dysfunction to the bowel. They can get diarrhea. Other causes of diarrhea because of short bowel, somatostatin use. Classically, the IBD, IBSs we spoke. We haven't spoken much about celiac disease today, but 1 in 100 Americans have celiac disease if you look for it with testing, and that's quite a big number. And celiac disease gets treated because of an osmotic cause of diarrhea because of malabsorption related to gluten sensitivity. And in those patients, you need to be on a gluten-free diet. So there are many, many, many causes of diarrhea in patients who have neuroendocrine tumors, and it's not always going to be from the symptoms. And as I've also alluded to, and we can talk about in question time, patients get symptoms because of the treatment, because of the SSAs, because of the surgery, because of consequence of tumors in unusual places. And so these are the conclusions of what I've hoped to help you with today. Neuroendocrine tumor management requires attention to syndromic symptoms in addition to tumor growth. About 30% of patients will present with syndromic symptoms. In a way, it would be a good thing because it potentially is an option to find this tumor sooner. Somatostatin analogs are the initial drugs of choice for syndrome management in almost all of these patients. It also is being used primarily because of tumor control. Some conditions don't respond as well, and we've discussed those today. Telotrestat ethyl is useful for symptom control in refractory carcinoid syndrome with an SSA in patients who have stable tumor. Of course, if the tumor is progressing as well, that needs to be addressed too. Zollinger-Ellison syndrome or gastrinoma is best managed with proton pump inhibitors because they block the final common pathway of gastrin stimulation. However, with metastatic disease, one needs to address the tumor as well. Malignant insulinoma may be difficult to manage medically and surgery. PRRT and or liver-directed therapy, which I didn't specifically comment on, should be considered in patients who have refractory insulinoma if all other therapies aren't very helpful. And remember, symptoms are not always syndromic. The impact of surgical and medical interventions have a significant effect on quality of life, and I would put SSAs in that specifically. So thank you very much for your attention, and have a good day.
Thank you, Dr. Metz, for that incredibly informational presentation. I'm so excited to have you here today. You are such a wealth of information, and we learn so much from you every time we talk to you. So I just want to really appreciate all that you've done in the field over the last 28 years and even into your retirement. So thank you for being here.
Pleasure to be here today, Lisa.
Great. And just before we get started, just a reminder for our audience that this question and answer session is for educational purposes only. It does not substitute for medical advice. We're taking general, non-case specific questions, and we encourage you to talk to your medical team about specific questions or concerns about your individual care or treatment. So Dr. Metz, as you know, we have over 30 questions. It won't be possible to get to them all, but we're going to try to get to as many general questions as possible. So the very first question, it's actually a combination of two questions. There's a lot of questions around carcinoid syndrome, which you covered very nicely. The first question is, does carcinoid syndrome always mean metastatic disease? And could monitoring flushing or other symptoms be used to indicate progression or worsening of the cancer?
That's a very good question. So the syndrome requires the products that lead to the symptoms we spoke of. And that is primarily serotonin derived, but might be from other substances like kallikrein and substance P and other things that are produced by the tumor. However, those products, when they are produced, can be inactivated in the liver. And since most carcinoid syndrome patients have a primary tumor in the liver, in the small bowel, the products are released into the liver through the portal venous system and often inactivated. So those patients may not present with syndrome even though their tumor is making the products. By the time the tumor spreads from the primary site to the lymph nodes to the liver, then the metastatic tumors in the liver are producing the product that gets into the regular systemic bloodstream and then causes the symptoms. So most patients who present with syndromic carcinoid syndrome will have had a primary that is already metastasized. On the other hand, that's not the only site for carcinoid syndrome producing neuroendocrine tumors. And other sites could be the lung, in which the tumor would release its products into the bronchial circulation, and that would go straight systemically and cause symptoms. In fact, people say that's a slightly different type of flushing that occurs, but it's also carcinoid syndrome and doesn't require metastases. And then another unusual site is testicular or ovarian primaries, because the testicles and the ovaries, especially on the left side, drain directly into the inferior vena cava and go straight to the heart, bypassing the liver. It's not in the drainage of the portal venous system. So primaries in those sites can lead to carcinoid syndrome without the existence of metastatic disease. Now, the other half of that question was about progression. And there's always been a tremendous controversy regarding looking at markers as either being predictive of outcome or as being predictive of progression or regression. And I am very wary to do that. So I wouldn't say if your 5-HIAA in the urine is 23 on day 1 and has gone down to 18 on day 30 after you've received some kind of therapy, say with an SSA, that means you're responding to treatment. Your syndrome is certainly responding, but that doesn't necessarily mean that tumor growth is responding. So it's very, very hard to be sure about monitoring for progression, and that is why what we really use is imaging studies.
Thank you. This is an interesting question. Can non-secretory NET transform to secretory carcinoid?
Well, that's a very interesting point. So the first thing, as we alluded to, you could have a carcinoid syndrome producing tumor that is growing but hasn't reached threshold in the blood to cause symptoms, and by the time it metastasizes, that does occur and your carcinoid syndrome develops. But what I think is also very interesting is talking about tumors that develop secondary hormonal syndromes. This is more common in patients with multiple endocrine neoplasia, but it can also occur with sporadic tumors, and especially very wide sporadic tumors. And so it is possible that you have a non-functioning tumor that then in due course starts making other products. Remember, the syndrome requires the product in the blood. You might have cells that would stain positive for various hormones that aren't necessarily released, but as the tumor grows and spreads and becomes more differentiated or de-differentiated, additional products can be produced. And classically, we see a disease called Cushing's syndrome, as opposed to Cushing's disease. Cushing's disease is caused by regularly a benign tumor in the pituitary gland releasing ACTH, adrenocorticotropic hormone that may increases cortisol. But Cushing's syndrome can be caused by exogenous cortisol, either administered by injection or orally as a therapeutic. So Cushing's syndrome can be a side effect of steroids, but it also can be an ectopic ACTH production, and classically widely metastatic neuroendocrine tumors all over the liver can at times produce a secondary hormonal syndrome like the ACTH-oma, or other products like growth hormone release, and acromegaly is another sort of end-stage ectopic tumor release. So these tumors may change with time. That usually signifies progression of concern with a change in the differentiation of a certain clone within these tumors, and it is something that is very important for you to follow up with your physician.
Yeah, and I'm wondering if this question is also asking if a tumor can go from non-functional to functional. So someone who doesn't have diarrhea and has a non-functional NET to something like one of the syndromes you're talking about.
So I think, as I said, I think that is feasible. I think, for example, the PPoma, which is a pancreatic polypeptide releasing tumor in the pancreas, very common in MEN patients, but most non-functional neuroendocrine tumors would have PP measurable in the blood. Interestingly, if you inject PP into somebody's veins via continuous infusion, they do get diarrhea. But in the PPomas per se, they don't have diarrhea. So we don't quite understand why that is the case. But can a non-functional tumor develop functionality? I don't think it's a common issue, but I think it can occur. And I think if it does occur, it signals either another primary, especially in MEN patients, or possibly very widespread aggressive disease developing. And so that would be a concern. Remember, MEN1 patients can have multiple tumors in multiple places. And if an MEN1 patient who's had stable tumor in the pancreas, for example, probably PPoma, suddenly develops insulinoma symptoms, then you have to think, well, maybe there's a different tumor. Which is the tumor causing the insulinoma? Which is the tumor releasing the PP? It's often very difficult for physicians to work that out. So you can have more than one tumor producing different syndromes, or you can potentially have a tumor progressing to make additional products.
Yeah, that's a really good point. Different tumors. Thank you for talking about diarrhea and the different causes of diarrhea. And you also mentioned short bowel syndrome towards the end of your talk. So how do you distinguish diarrhea caused by the excess serotonin and carcinoid syndrome to that caused by the short bowel syndrome?
Well, that's very difficult in clinical practice to necessarily know it. And in many patients, the diarrhea may be multifactorial. So syndromic diarrhea is treated best with somatostatin analogs. Of course, excess of somatostatin analogs, especially in people who may have had pancreatic resections or small bowel resections or some other reason for having a diarrhea underlying it, can lead to pancreatic insufficiency and steatorrhea. That's a fatty diarrhea, and it's a different kind of diarrhea. Now, steatorrhea occurs after eating because you have a lot of fats in the food that is not properly digested, that leads to fatty diarrhea and stooling. Syndromic diarrhea is a secretory diarrhea. That's a diarrhea that's usually watery, and it occurs regardless of whether you eat or don't. And it actually occurs at night and can wake you up from night, and it's relentless. It's worst in vipoma, also seen in gastronoma, and also seen obviously in carcinoid syndrome producing diarrhea. And then all of these causes of diarrhea are interacted with two other potential groups. One group is underlying causes of diarrhea that anybody can get, whether they have a neuroendocrine tumor or not. So there's no rule why you can't have celiac disease, or you can't get an infectious diarrhea, or you can't, lo and behold, I hope it never happens, get inflammatory bowel disease on top of it, or irritable bowel syndrome, which is extremely common. So existing other causes for diarrhea can exist, it can be there as well. And then, as the question alludes to, short bowel syndrome or resection of the bowel. So we need to talk about that. Short bowel, by definition, means less than 75 centimeters of existing bowel. And that means not enough bowel to digest an appropriate diet, so that you get maldigestion causing an osmotic diarrhea because you just cannot absorb it. But in addition, especially patients with neuroendocrine tumors, they're predisposed to having terminal ileal resections. And so if you remove the small bowel, the terminal ileum, the last part of the ileum, you may still have way more bowel needed to not get typical short gut, but you lose the terminal ileum, and the terminal ileum is important for absorption of vitamin A, D, E, and K, and fat. And so as a consequence of that, you can get a malabsorptive syndrome because you've lost the terminal ileum. And furthermore, as many patients with neuroendocrine tumor have, as they may have lost their gallbladders, because we know that somatostatin analogs are associated with gallstones. And so often when they're in there, the surgeons remove the gallbladder prophylactically. And the bile salt pathway, which is produced in the liver, comes out through the bile duct into the small bowel, and then reabsorbed in the terminal ileum to be reused. Those bile salts are very important to saponify fat and allow fat to be absorbed in the terminal ileum. So if you've lost your terminal ileum and you're still making bile salts, whether you're storing it appropriately in the gallbladder or it's just leaking out all the time, those bile salts can get into the colon where they irritate the colon and cause colitis. So that would be bile acid associated diarrhea. And generally speaking, if you've had a terminal ileal resection, there's no value in doing all these bile studies because we know that's happening. And then you want to treat with a product that binds up bile. So cholestyramine is used to bind up bile. That's used to lower cholesterol, in which case it's given with meals. But if you want to use cholestyramine to avoid bile acid diarrhea, you should give it away from meals and away from all other medicines because it can bind up the medicines so they're not absorbed. And then you want to try and get rid of the free bile and limit it getting into the small bowel because there's no terminal ileum. And finally, the two other causes we need to think about. One of those is adhesions. So anybody who's had bowel surgery might have kinking of the bowel and poor motility of the bowel as a consequence of surgery that can interfere with motility and give you overgrowth symptoms and diarrhea. And then there's just classical bacterial overgrowth. Bacterial overgrowth is in patients who are on acid suppression medicines so that they don't have acid in their stomach and they can swallow bacteria. In addition, people who've had anastomoses, so they have dysmotility and stagnancy in the bowel. People who've had piping reorganized because of various surgeries like a Whipple's operation. People who've lost their ileocecal valve because of surgery where the small bowel joins onto the large bowel, where most of these small bowel neuroendocrine tumors do occur. All of those sorts of causes lead to normal bowel colon contents moving up into the small bowel, and you can get overgrowth of bacteria in the small bowel, and those bacteria compete with your body to digest any food that you eat and give you rumbling and grumbling in the stomach and diarrhea from bacterial overgrowth. That would be treated with antibiotics. So you need to think about bacterial overgrowth, you need to think of short bowel, you need to think of malabsorptive conditions, bile salt diarrhea, and then all the other causes of diarrhea anybody else in the world can get, like celiac disease, inflammatory bowel disease, irritable bowel syndrome, infections, etc. So it's complicated, and it requires a doctor to take the time with the patient to go through the various types of diarrheas, how they present, and how they differ one another clinically to manage them.
Thank you for that very thorough answer. So there's some follow-up questions that are related. So we talked about short bowel. Could you share some short bowel syndrome resources and suggestions for thickening output and slowing motility?
Yeah, well, you know, there's stuff called Thicken that people use for patients that have difficulty swallowing or dysphagia, who've had a neurological abnormality in the throat. And if they have liquids, they can aspirate. And Thicken is used for that group, but it's not going to have any difference about thickening up anything further down in the bowel. However, there was a substance called Crofelemer, Crefolemer, that is FDA approved for diarrhea in HIV patients. And it is available as a medication, and I think it can be prescribed and tried as a way to sort of prevent diarrhea, secretory diarrheas from being unmanageable. And I think it's always worth a try if you have terrible diarrhea that's not controlled with somatostatin analogs or cholestyramine and antibiotics. There is another substance called guar gum, G-U-A-R gum. It's a natural occurring substance that we have used in the past a lot for irritable bowel syndrome without much really good data. So sort of, this is sort of an ad hoc use. Guar gum is used for irritable bowel syndrome, both the diarrhea irritable bowel syndrome as well as the constipation irritable bowel syndrome. So I'm not sure how it necessarily fits in, but some patients might find that that's a useful approach. A low-fat diet is always important in patients who are on somatostatin analogs, because I think fat is probably part of the story with steatorrhea rather than secretory diarrhea. And many patients get diarrhea that is timed with their somatostatin analogs. And although this hasn't been very well studied, I think that early on in the course of after your injection, it might be insufficiency, and later on, before the next injection, it might be syndromic as the drug wears off. So people need to learn to modify their diets. And of course, then there are lots of other foodstuffs like sorbitol and diabetic sweets that can cause diarrhea as well. Some people have difficulty with apple juice, for example. So I think it's very important for neuroendocrine patients to see a nutritionist at least once to get a handle on how best to try and eat with their specific anatomy and their normal food dislikes and likes, to try and find out the best way to manage these symptoms, because it's the symptoms are sometimes worse than the actual tumor itself for a long time as things go very slowly.
Thank you for that answer. And you actually touched on several questions that were also asked. But let's break it down. There is a question about bile acid malabsorption. How can you tell if you have bile acid malabsorption diarrhea? And I think, does it ever resolve? I think that was part of the question. And is it based on identifying symptoms and response to cholesterol?
Yeah, so it's interesting. Many patients, if you have a gallbladder removed, will tell you they're now getting diarrhea. And that's whether they have a neuroendocrine tumor or not. And so the gallbladder's job normally is to store bile salts. And then when you eat, and the food and acid moves out of the stomach into the duodenum, that stimulates two other hormones, secretin and CCK. And they work on the pancreas to make pancreatic enzymes for digestion, and on the gallbladder to contract and release bile to saponify fats for absorption. So if you've lost that storage capability and your bile salts are just dribbling out all the time, and the timing related to meals isn't necessarily there, if you have a terminal ileal resection and you're not reabsorbing all those bile salts, you can certainly get bile salt diarrhea. There are ways to test for it. You can measure, there's a breath test that can be done. I know the Mayo Clinic has been doing some studies recently on bile salt diarrhea and objectively testing for it. I think it's not generally available everywhere, but can be considered. I would rather, or clinically, I think it's practical to just try go with a cholestyramine binding therapy like cholesterol or cholestyramine or one of those, and take them away from meals, and very importantly, away from other drugs. Don't run the risk of controlling your diarrhea and then losing your thyroid control because your thyroid hormone isn't getting absorbed or whatever other drug you're taking.
Thank you. And you also talked about seeing a nutritionist. There were actually several questions around this. And this is kind of a general question. Do you have any supplements or food that would help with the diarrhea, especially post-surgery? But there's also a question about how do you find a nutritionist to help address these issues?
Yeah, a very difficult problem in the United States at the moment because dietitians are very, very hard to find. Many programs, I think a good neuroendocrine program should have access to dietitians. Most cancer programs do have dietitians. And so all your doc should really be able to need to do is to just put in a consult to get a nutritional consult. But I can know from practice when I was working, it's easier said than done in many situations. But there are lots of nutritionists who work privately as well. I would recommend at least one good nutritional consult because many of us live a lifestyle of what we like to do, but it's maybe not necessarily the best thing for our health. And as I've always told my patients, do as I say, not as I do, because I'm not the most responsive person myself when it comes to my own health. And we all like eating what we're eating, and eating is one of nature's pleasures. So we need to be able to try and eat what we want as well as we want within parameters. And if you've got an underlying syndrome, it's obviously that much harder, and I think nutritionists' help is certainly something that should be sought. I think there are a number of handouts from the various patient organizations, and Lisa, you may have one at LACNETS on what's the appropriate diets and how people can count calories and what goes in and what comes out.
Yeah, we have a resource page just on nutrition, including videos from dietitian and also some cookbooks as well. So that might be helpful. And also, this is a somewhat related question. For those with carcinoid syndrome-related diarrhea or any diarrhea, are there nutrition tests you would recommend on a periodic basis?
Well, that's a good point. I don't think there's much value to over-test just to see what's obvious. And I don't think that patients need to be very concerned that their albumin level has dropped from whatever it is by 2 points to another number. So I don't think that measuring pre-albumin or albumin is really, really that important. Weight loss is a real concern in any patient with a neuroendocrine tumor. So if you're not maintaining your weight, I think then you do need to be evaluated. I think that's a concerning finding, and that to me often relates to tumor progression. Vitamin deficiencies is another story, though. And I think, vitamin A, D, E, and K are absorbed in the terminal ileum. Vitamin B12 requires a terminal ileum for appropriate absorption. And so I think it's reasonable to every now and then perhaps get a sort of panel of blood counts, an SMA-20, which is a general sort of electrolytes and renal function and liver function test, and possibly every now and then a B12 and a prothrombin time, which measures the vitamin K, and calcium is something that's always measured, so that would fit in with the vitamin D component. So I think these things should possibly be tested on occasion. I don't think there's any need to go overboard and get all these nutritional counseling and learn about potential allergies and things. I don't think that helps. I think have a healthy diet, good protein, fat, and carbohydrates, and a generalized diet. And only thing that I think is the signal to be wary of is weight loss.
Okay. As a gastroenterologist, I imagine you've been asked this quite a few times. Are there any advantages to an organic or non-GMO diet?
Well, I don't want to hang out a hat here one way or another definitively. Many people feel that it's healthier to have organic food. I think what's really important is to have a nutritional balanced diet rather than necessarily something that's organic or specifically done without, antibiotics and grass-fed animals and that sort of stuff. But I think I'd like to plead the Fifth Amendment on that one.
That's okay. Going back to carcinoid syndrome, and you covered this at the very beginning of your talk, what is the most accurate test to check for carcinoid syndrome? Is it urine or plasma 5-HIAA more reliable?
Yeah, so remember, carcinoid syndrome is as a result of more than one product, but what we really use as the product that we measure is the serotonergic pathway. And the final common pathway of that is 24-hour urine 5-HIAA. And that's the test that has been specifically validated. Now, lugging the jug is a hassle. What happens if you've got renal dysfunction? I'm not really sure. I don't think it alters it in a major way. But why can't you just measure the blood? So plasma 5-HIAA has been done. And it would show from the available data that it is actually a validated test. So I think that a plasma 5-HIAA done in a good lab probably is as good a reflection as 24-hour urine 5-HIAA. But it's very difficult to be sure in my own mind how this all works. The studies have shown that the correlation is very, very good. But if I give you a sudden fright, and you suddenly jerk up and get all anxious and your fright is switched on and your serotonin shoots up high, and many patients will know that. If you suddenly get all scared and you jump out, you're going to flush. Well, if that's the case, I imagine your blood 5-HIAA would potentially go up, and at least your blood serotonin, which is upstream of it, may go up. So some people don't like using blood serotonin levels because they think they're too variable. Although I know a particular surgeon I worked with closely felt the serotonin was more valuable than 5-HIAA. But that's all anecdotal stuff. The data suggests urinary 5-HIAA is the gold standard and that plasma 5-HIAA works. I don't know about the plasma or serum serotonin levels necessarily being any better or, better. I don't know if they're better. They're probably not better, but they might potentially be worse. I don't know how much worse. And then, of course, all the other products, we don't sort of measure your kallikrein level and your substance P levels, but these are substances that work out of the bloodstream. So what the actual level is in the bloodstream may not reflect the syndrome. And so it's a really difficult answer to be absolute about, but I think if you get a 24-hour urine 5-HIA, you're doing great. And if you want to get a plasma 5-HIA, I don't think there's a problem with doing that. Other tests, I don't know if I would trust as reliably, but again, that's controversial.
Thank you for that and covering all that very thoroughly. So we've talked a lot about diarrhea. Do you see patients with chronic constipation after resection instead of short bowel syndrome? And if so, what's the recommended treatment?
Well, constipation in a patient with carcinoid syndrome is a big worry and may relate to bowel obstruction. Remember, the tumor in the mesentery causes kinking and fibrosis. There are some patients that get peritoneal disease that can cause obstruction. And so if you develop sudden constipation, I think you need to be very wary in that situation. Of course, based on anastomoses that can be overly tight and strictured, that could potentially also be a cause of constipation. But constipation really is not a typical finding, although remember that when bowels get resected, the nerves, the enteric nerves that run along to that segment A talks to segment B and talks to segment C, you lose that after you've had an anastomosis. And so dysmotility or abnormal motility is common, and if patients develop relative constipation after resections, I think a high fiber diet is always something to think about to help keep the bowel distended and maybe avoid a constipation as such. Telotrestat ethyl has limited specific indications, but it has a very good use in patients who have syndromic disease from carcinoid syndrome, not from the other functional neuroendocrine tumors, because it only blocks the pathway of the carcinoid syndrome tumors. But if that is blocked with telotrestat ethyl, many patients would tell you that they developed constipation as a so-called side effect. I mean, it's not really a side effect because it's an expected effect. And in that situation, you need to cut back on the telotrestat. And I've heard from patients that it can be quite significant. Remember, that drug is indicated in patients with stable disease who have ongoing syndrome despite an SSA.
It's as though you read someone's mind, because they actually asked the question if taking Zermelo, telotrestat for carcinoid syndrome, if it causes constipation, can it be taken at a reduced dose, and can the pills be cut in half? So there you go.
That's interesting. I'm not sure about cutting pills in half, and I don't want to comment on the formulation itself per se. You need to be careful when you cut medications in half if they are able to. Some tablets that are scored can certainly be cut in half, but you obviously can't take a capsule, half a capsule, and it might have enteric coating on it, so I'd be wary of cutting it in half. But what I do think is totally appropriate is reducing the dose or taking it less frequently, and even potentially on a PRN basis.
Okay, as needed basis. You mentioned in one of your previous answers about fat malabsorption after getting a somatostatin analog, the somatolin depot or octreotide shot. Does it occur immediately or over time?
I don't know the answer to that definitively, because you've got to realize that as time goes on, tumor changes, even though there might not be any obvious reason for change in the actual tumor bulk and where it is and what it's doing and how it's acting. So there's many causes for why things might change with time. I think that anecdotally what I've heard is that patients are so much better when they go onto the somatostatin analog the first time around that they sort of tolerate maybe more diarrhea than they would be tolerating later. That's one possibility. And then obviously the other possibility is as the tumor grows and it might make more product, they might need more drug. That's another possibility. And then there's this whole question of what's called tachyphylaxis, loss of efficacy with time. Now, one of the uses for somatostatin analogs is by continuous infusion intravenously to control venous pressure in patients with portal hypertension who rupture the portal vein and get massive upper GI bleeding. And in that situation, there is tachyphylaxis. It's been shown that continuous infusion IV somatostatin 50 micrograms an hour, which is the same sort of a dose as we give in the depot, but much quicker, or continuously infused, that does have tachyphylaxis associated, so it may not work as well with time. So anecdotally, some patients are talking about the fact that they may lose that effect on the syndrome. So in that case, it's not fat malabsorption, it's loss of efficacy of the somatostatin analog and worsening syndrome. On the other hand, as the pancreas dries up from excess of somatostatin analog, or as you develop worsening atrophy in the pancreas because of your previous surgeries or whatever else is going on in the pancreas, could you develop worsening steatorrhea months and years after starting the drug? And I think that is a possibility, but again, not very easily studied in a specific pace. So the beauty of it is that you can diagnose steatorrhea relatively easy. So exocrine pancreatic insufficiency can be measured by doing a stool elastase test. And a stool elastase test is a test of a stool that looks for the enzyme elastase. And elastase is a pancreatic enzyme that is not acted upon in the body. And so the pancreas makes elastase, it comes out in the stool, and if the level is low, then you're not making enough elastase, and you can infer from that that your pancreas isn't making enough enzymes. A couple of very important caveats to that. You have to use a formed stool, because you can imagine if you're getting diarrhea in a liquid stool from a secretory diarrhea or from any other cause of diarrhea, like even viral gastroenteritis, you're having so much fluid in the diarrhea that it's diluting the elastase that's there, and you'll get a false negative test. And even patients with irritable bowel syndrome, they can get a false negative elastase test in some studies as often as up to like about 10% of the time. So it has to be a formed stool, and it has to be at a time that you're getting fat malodorous stools. When would you do it in relation to a depot octreotide injection? You'd want to do it when the octreotide is away from the action as much as possible. So if you're going to look for steatorrhea, you would expect that it would be worse immediately after your injection, when your levels in the blood are potentially going up, and that it would be least towards the end of the injection before the next injection. So I would say if you get diarrhea for 2-3 days after your depot injection and it goes away in the middle, and then it doesn't come back at the end, you're looking possibly more at steatorrhea. You can get a stool elastase at that time. But on the other hand, if you get your depot injection and you don't get diarrhea early on, and you do fine through the course of the month, and towards the end of the month you start getting a watery diarrhea, then I think you might be having a pancreatic enzyme somatostatin analog that isn't working well enough through the whole month, and then maybe you talk about shortening the interval. So it's, I think, theoretically possible to get steatorrhea early on and syndromic diarrhea later on, and separating out the two really requires taking a good history. Is it related to food? Does it smell terrible? Does it float in the pan? That's more steatorrhea related. Does it occur 24/7, even if you fast, especially at night, waking you up and it's watery? That's more syndromic in nature. And then you have to factor into that, of course, all those other causes we discussed.
Yeah, that's very helpful. And we don't want to leave people with just the workup. What about the treatment? Is there one pancreatic enzyme that's better than another? What do I do if Creon is not covered?
Yeah, so if your enzyme is not covered, I think the thing to do is have a nice, good fatty meal. Wait for a fatty stool, go to your doctor and ask them to measure a stool elastase, and if it's low, it's very hard to deny a therapy if you have proven a low elastase in the presence of steatorrhea, which is what you're proving. There are some enzymes that are more expensive than others. Viocase was the old trade name for pancreatic enzymes that were not enterically coated. Remember, depending on the piping related, some of these enzymes are acid labile, some of the pancreatic enzymes. And so if they're not working well enough, our doctors used to prescribe acid suppression agents like cimetidine or famotidine to be taken with the enzymes to protect them through the stomach. But nevertheless, I think if you get enough of a dose, it doesn't matter. So I think any of the pancreatic enzymes can potentially be used. And that's, again, where a nutritionist is helpful. I think it's important to take the enzymes before you eat, while you eat, and after you eat, so that you spread it out in the meal, especially if you've got an abnormal reservoir in the stomach, or you've had a Roux gastric bypass and you might be having dumping or something like that, so that they at least mix properly. But I don't think that there is a completely limiting effect to say Creon works and the others don't. But I think you need to be a little bit more inventive with how you take them if you aren't having a well-prescribed, acceptable enteric-coated enzyme.
Thank you. And we'll just end with this last question. I mean, you've seen the community through 28 years of service. What final words of hope would you like to share with the NET community as we close?
I used to say that I was going to grow older with my patients because this is a slow-moving disease that we can always manage and control. I'm beginning to think that some of my patients may now do better than me as I'm getting beyond those years. So I think the important point is don't lose hope in this disease. I think it's important to go slowly and step by step. Don't use up all the possible treatments too quickly, because you might need something later down the pike. Make sure you have a multidisciplinary group looking after you that looks at the whole patient rather than a hammer, with a nail. Things are changing all the time. I mean, the most recent dramatic, obvious, totally changing treatment was the PRRT, which is now being fine-tuned with different kinds of PRRT. But prior to PRRT, I would say that patients had a much bleaker outlook, and now, as long as you've got somatostatin receptor positivity, that clearly provides definitive survival time and good quality survival time. So I think things are changing. Make sure that you have a good group looking after you who are looking at all the possibilities. Go with what's available for now. Realize that more things are coming along the line. And most importantly, make it a quality of life experience. And so dealing with these symptoms is really, really important. It's horrible to be miserable and alive. It's much better to be alive and functional and taking appropriate therapy to keep you doing as well as you can. But it's a chronic thing. Think of this as a chronic, long-standing disease rather than galloping cancer, as I think many people are scared it is.
That's right. What a perfect way to end it. It's about quality of life. We want people to thrive. And thank you for your years of service. Thank you for your insights and your wisdom. And now I'm going to turn it back to Heather in the studio.
Thank you again, Dr. Metz, for that thorough and helpful presentation and for answering those important questions from our audience. Educational programs like today's are made possible by our supporters: Ipsen, ITM Pharmaceuticals, Advanced Accelerator Applications, and Crinetics, and also by donors like you. Please consider making a donation today at lacnets.org/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality broadcast production. Again, follow us on social media to stay up to date on our current events. Our handle is @LACNETS. And now back to Lisa.
Thank you, Heather. LACNETS is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, lacnets.org. LACNETS also has a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. Thanks again for joining us. Goodbye, and we hope to see you in real life on November 11th in Santa Monica.